Hello, my name is Christoph Röllig. I'm a consultant hematologist at the University Hospital in Dresden in Germany, and I'm happy to give you a brief overview about my highlights from the topic of targeted therapy in acute myeloid leukemia from this EHA meeting 2026. So actually, in AML, we have abandoned the concept of one size fits all to our treatment. And during the last couple of years, we've seen the emergence of targeted agents that actually work in subgroups of AML. And there are more targeted agents now available. And the, let's say, most promising ones and the ones which are most advanced in clinical development have been presented here in various presentations and also oral abstracts and posters. There are basically 4 groups that I'd like to talk about. The first one is menin inhibitors. It's a very popular topic and many novel agents are in clinical development. Then there are the BCL2 inhibitors, not only venetoclax, but there are also others around. There's FLT3 inhibitors and also immunotherapy. So as opposed to other hematological entities, we now hope that immunotherapy will also play a role and improve the outcome of patients in the AML field. So let's start with the menin inhibitors. In general, I can say that both for all agents, menin inhibitors, FLT3 inhibitors, immunotherapy, but also BCL2 inhibitors, there were very nice educationals that I can refer to if you're interested to go into the topic in more detail, that covered the whole spectrum of preclinical, clinical development, but also novel developments of these agents. When it comes to menin inhibitors, we've seen presentations both on the basic mechanisms of action, but also on resistance development. And we've seen several posters and all presentations on the different clinical stages of development for the several menin inhibitors that are around, such as ziftomenib, revumenib, enzomenib, and others. And for instance, the large clinical trial, a single-arm clinical trial adding ziftomenib to intensive chemotherapy 7+3 was made it as an oral abstract, and the results are quite encouraging in patients with NPM1 mutated and KMT2A rearranged disease. When it comes to BCL2 inhibitors, of course we are interested in resistance mechanisms to venetoclax combinations. There were also presentations on novel BCL2 inhibitors because it's not only venetoclax anymore, but there are several more, some like for instance on rotoclax or lisaftoklax. And also we are still interested in how to optimize our treatment with venetoclax. And one burning question was, what's the best dosing regimen for venetoclax in the first line of unfit patients in the combination with HMAs? And the OPTI-AML study did a randomized comparison of 14 versus 28 days of venetoclax. The answer or the result of this trial was not as easy as we hoped. So what we found out is there are subgroups who do benefit from a more dose-intense treatment, such as IDH1 or NPM1 mutated patients, and there are other subgroups for whom it doesn't seem to be necessary to go for such a long period of time. When it comes to FLT3 inhibitors, we've seen a nice educational with an overview, and there is one abstract as a late-breaking abstract comparing the efficacy of gilteritinib versus midostaurin as addition to intensive chemotherapy in newly diagnosed fit AML patients. That's the results who were awaited for quite a long time. And the outcome is slightly disappointing for clinicians and for patients because we hope that gilteritinib would prove to be superior over midostaurin. But in the end, the primary endpoint of overall survival was not met. So the overall survival of both treatment concepts is quite similar for gilteritinib or midostaurin in combination with intensive chemotherapy. And last but not least, as I mentioned, we are all hoping that immunotherapy will play a bigger role in the treatment of AML in the future. So we've seen one very interesting novel agent that is an allogeneic CAR T cell against CD123. And the special thing about this is not only that it's an off-the-shelf allo-CAR T, but also that it's switchable. You can switch it on and off with a linker molecule that you infuse. So if you have side effects, adverse events, and you stop the infusion of the linker molecule, the activating linker molecule, you can switch the activity of the CAR T cell off, which is very good in terms of toxicity management, for instance. Beyond that, we've seen other CAR Ts against CD33 or CD7, and all together that raises our hopes that with further clinical development, immunotherapy will enhance or will benefit patients and improve their outcomes. And with that optimistic view, I thank you for your attention, and you can dive into more information when you go to the EHA platform and look into the specific presentations. Thank you for your attention.